So they roll in, we give them their 60 seconds to give their report in silence while we're transferring them over everything, getting everything. I turned to my physician partner and I said, dual sequential? And she goes, yes. So of course the nurses had never heard of it before because it was novel at the time.
Yeah.
So we wheeled in a second crash cart. He was already on the anterolateral pads. He rolled them, got them on the anterior posterior pads. I told the nurses, I'll take care of everything. You guys just, watch. And next time it came around, he told me, fib, shot. We got a rhythm.
Nice.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and I hope you enjoyed part one of this two-part series on the deep dive for ACLS with my friend Andrew Bowman. If you haven't listened to the first episode, you might want to listen to that episode first and then come back to this one. This is definitely a part two, but we're going to get into a little bit more about the ACLS algorithms, some of the medications you use, and we're going to be talking about some novel therapies that I've put a bunch of links to in the show notes. There's a bunch of links in the show notes that you can take a look at. Lots of EKG and ACLS articles. So I hope you enjoy. I'm going to jump right back into it with my friend Andrew Bowman. Now, talked a little bit about epi. We talked a little bit about the shocks. What other medications for this kind of pulseless VTAC, VFib?
So, your old
medication.
standbys, amiodarone and lidocaine. Oh, so currently, American Heart says, you've got a couple shocks, you give your dose of epi, you've got another shock, you're still in VFib, pulseless VTAC. Now you give a dose of amiodarone, 300 milligrams IV, circulate that. You can repeat that 150 a couple different times. You can throw in lidocaine, 1 to 1.5 milligram kilogram. But in 2016, there was a study that came out called the ALPS Study, amiodarone lidocaine placebo study, that looked at, do those drugs actually work for VFib, pulseless VTAC? And they found that maybe slightly better amiodarone, but overall, none of those drugs did any better than placebo in the grand scheme of things. Now, more recently, they've done some more deep diving, tearing apart the data and the research on the original ALPS study. And they now are saying that if you get amiodarone on board before 8 minutes of cardiac arrest, it probably works better.
Interesting.
Okay. Well, in the field, you're not going to have that unless it's a witnessed arrest.
Yeah.
They move down in front of the medics. In the hospital, you might. So, but overall, so really, amiodarone and lidocaine probably don't work as well as we would like for them to, for that person in with pulseless VTAC.
I think I've given amiodarone during a code a handful of times, and I can't remember the last time we gave lido.
Yeah. In fact, one of the doctors I work with prefers lidocaine, but again, the stage, so they probably don't really work more one than the other. What I found interesting last year is, I'm sure you remember Bertilium, read all of Stellate. It may become.
I don't think I ever gave it in my career, but I remember it.
Am I that much older than you, man?
You might be.
I used to give it a lot.
I don't think I've ever given it.
Yeah. But then the material that it was created from kind of couldn't be accessed or something. So it didn't make it anymore. Well, I just read last year that it may be coming. So Bertilium may be re-entering the fray of the treatment of VFib cardiac arrest. Remains to be seen. But, it was, there was always the phrase, shock. Everybody shocked. So E was for epi. Big shock, Bertilium. Little shock, lidocaine. People shock, procainamide. So we had this whole thing, trying to remember all the drugs. So really right now, try amiodarone, try lidocaine, but again, probably it's not going to be as effective as we hope.
Yeah.
Now, the one drug that I've really fallen in love with, and there's now a lot more research going on for that patient who stays in VFib. You've done your high quality CPR, you've got your initial shock in, you've got your second shock in, you've given a dose of epi, you get shocked again, they're still in VFib, may or may not have tried amio or lidocaine, but the next drug to reach for is esmolol.
Interesting.
beta blocker. Because what's happening with VFib? This is a sympathetic driven rhythm, and we're given epi to even drive that sympathetic stimulation even harder. And so finding now that we can kind of block that sympathetic discharge, that next shock may stop their VFib from coming in. So you give Esmolol 500 mics per kilo as a bolus, and you start a drip starting at like 50 mics per kilo per minute. And
I've not done that in.
done it a few times. Done it a few times.
Nice.
And I think we there's opportunity here too, if we can kind of loop this in back to our defibrillation strategies of vector change and dual sequential defibrillation.
What is vector change? So I'm familiar with dual sequential defibrillation. Not familiar with vector change. What is vector change?
So there's a emergency doctor, EMS doctor up in Canada named Dr. Cheskus, who in 2020 came out with what's called the DOSE VF trial, DOSE VF. So he was comparing standard defibrillation, vector change, and dual sequential. So standard defibrillation is your anterolateral pad placement, properly placed lateral pad in that good position. Vector changes after a certain number of shocks. If they're still in VFib, you go from anterolateral to anterior posterior.
Okay.
Go to a different direction of your pads to deliver your. Then, of course, there's dual sequential, where you have you both anterolateral and anterior posterior pads on, hooked up to two separate defibrillators, and you shock. So it's dual sequential, not dual simultaneous. That's where a lot of people have got into some potential issues with defibrillator damage by doing it simultaneously. They found in the original dose VF and then in the subsequent follow-up study that he did in 2022, that when you did it dual sequential, shock, there was no defibrillator damage.
Okay.
And that was always the original concerns was, is doing dual defibrillation going to damage my defibrillator and it's not covered under warranty, and we're going to have this block of brick over here that doesn't do anything.
Now,
so some defib companies that are kind of pulling back on their concerns about dual sequential based upon these studies that show it doesn't hurt the machine if you do it sequential.
Now, my big disclaimer here as a for the podcast is follow your system's protocols.
Follow your
system's protocols. If you do not have a protocol for dual sequential defibrillation, discuss that, but follow your protocols. This is not
right.
This is something you don't want to be the first one in your department to do.
or your nurse-led code, do whatever your hospital says, here's what you do in a code. But I'm a nurse practitioner, I'm a provider.
You can
a little over free reign. Yeah. So the first time I ever used this for reals was about 8 years ago. And I've shared the story as on my ENA lectures at Nashville a couple times. This was a young man, early 20s, who years ago had SVT, but he had an ablation and he was SVT free on no meds. So everything's great. He's out one evening with some friends at a restaurant having he's 20 years old, college guy, wasn't drunk or anything. Just suddenly collapses. No prodrome, no warning, no complaints of chest pain, just suddenly collapses. Fortunately, someone started bystander CPR. They called 911, medics found him in VFib. Multiple shots by medics, airway, IO, epi, amiodarone, brings him to us, still in VFib. He's had like 8 shocks pre-hospital. I was just getting off shift. Since we were getting this code in, I stayed over to help out the night shift doc who was there single coverage. So they roll in, we give them their 60 seconds to give their report in silence while we're transferring them over everything, getting everything. I turned to my physician partner. I said, dual sequential? And she goes, yes. So of course the nurses had never heard of it before because it was novel at the time.
Yeah.
So we wheeled in a second crash cart. He was already on the anterolateral pads. He rolled him, got him on the anterior posterior pads. I told the nurses, I'll take care of everything. You guys just, watch. And next time it came around, he told me, fib, shot. We got a rhythm.
You're like, score.
We got a pulse.
That's awesome.
And
What
he
a
walked
cool
out of the
story.
hospital. He graduated college. He's a successful employed person and function member of society.
That's
That's
awesome.
great. That's great.
That's
So
awesome.
in the follow-up second study from Dosevia from Dr. Cheskas, clearly showed dual sequential was better for the person in persistent VFib.
Hmm.
Does not recommend starting with dual sequential. Start off with your normal stuff, your single interlateral pads, do 3 shots of that, and then consider a vector change, because sometimes, like I said before, for the interval of the patient, one position might be better than the other. But if vector change doesn't work, then consider dual sequential.
Nice.
So then, as all, of course, then if they're still in VFib, it might help your next shock to get them out. And then there's always, of course, a standby propiamide, but it takes forever to load up and probably not a great drug in a code situation. Probably reserve propiamide for that person who's in stable pulse VTAC. Who you can, propiamide is probably going to be better for them in the long run. But we're not, they focus on cardiac arrest here.
Very cool. That's great. That covers the algorithm. That covers the cardiac arrest algorithm pretty well. And we'll leave the people can review the actual algorithms in the book,
Right.
and go over like the H's and T's and that kind of thing. So some of the reversible causes that should be considered and then addressed if we think that's a possibility.
Yeah, I mean, the big things from your H's and T's in an emergency care setting, probably the biggest one is, are these patients who are hyperkalemic? Is this a dialysis patient who missed their last week of appointments and they are in cardiac arrest? The big thing about there is, is there K10 and do we need to revert that? So that situation is where calcium and sodium bicarb are still clearly indicated.
Yeah.
So that patient who comes in with a hyperkalemic arrest, routine use of calcium bicarb is not recommended by American Heart and other studies. But for the situation where you think you have a condition like hyperkalemia, calcium's the antidote for that, basically. It stabilizes the cardiac membranes. Bicarb will drive the potassium back into the cells. Other drugs to consider like dextrose and insulin, albuterol, high dose inhalation while you're bagging them, things like that, to try and get the K down. The other time when bicarb might be indicated is someone who's taken an overdose of a tricyclic antidepressant, because it can cause a wide complex tachycardia or, VTAC. And again, it can reverse that as well. So those are the 2 times to consider calcium or calcium bicarb is hyperkalemia and tricyclic overdose.
Now, and this might be part due to our population. I don't know, but it seems to me that very frequently our docs are calling for epinephrine and then a bicarb and a calcium, like pretty frequently.
They're still working in the 1980s and 90s, and they're still doing it. Calcium has no role in routine use in cardiac arrest. Sodium bicarb has no role in routine use in cardiac arrest. But think about what are particular causes. Is this some kind of sodium channel blocking thing like tricyclic? Is this hyperkalemia? Then those drugs do have a role that might be helpful.
Yeah.
The other thing in your H's and T's, and again, an emergency setting, are the 2 T's, thrombosis. Is this a PE that has caused cardiac arrest? Or is this, just a big MI from a, large vessel coronary occlusion that's causing them to go into VFib cardiac arrest? Sometimes we will give TPA or TNK in those situations. For the coronary thrombosis etiology, there was a study out there ago called the Troika study, TROICA, that looked at giving TPA at the time. We didn't have TNK yet when that study was done. It really didn't show any big difference giving TPA. It may be more helpful if you use a large pulmonary embolism to give a dose of thrombolytics such as TPA or now TNK, because TNK is so much easier to dose. It's just a bolus and you're done. Whereas, TPA was a bolus and a drip and stuff. The biggest thing is,
our hospital has gone exclusively to TNK now.
So all 3 of ours that we work on. So we did for We use it for STEMI if we don't have access to a cath lab in a timely fashion. We use it for unstable PE, and we use it for stroke. We use TNK.
And this is a little bit of a side note, but how does it compare to TPA as far as, are the results about the same for TNK and versus TPA?
As far as
For stroke?
for
particularly?
perfusion, it's pretty much equal to TPA. I think there's a couple things that the TNK might have a slightly higher risk of hemorrhage, but overall, it's not a big difference than TPA.
Yeah.
And as much as I am not a big fan of lytics for stroke, I think lambectomy is the way to go. I did recently give TNK to a stroke presentation who was improving. So something happened that got better. I've never been a big fan from day one of lytics for stroke.
Yeah.
Because we know in a heart attack, that's an acutely formed clot that is formed on a site of plaque rupture. That's a fresh clot. Yeah, it's going to respond to a clot dissolving drug because it's a fresh, brand new clot.
Yeah.
Stroke, we don't know, ruled out the hemorrhage by getting that STAT CT. There's no hemorrhage seen. So we're going to give it a try. We don't know if this was just a fresh clot that's formed in a similar fashion, a plaque rupture in a cerebral vessel, or is it a piece of plaque that broke off from a carotid artery? It's not going to work.
Yeah.
Or is this an old clot from the left atrium or atrial appendage from their AFib that finally broke off? So it's an old clot. It's not going to dissolve.
Yeah.
So I understand the thought process that, maybe there's a chance that it's a fresh clot, but I think more often than not, probably what we're dealing with, and these are a big piece of plaque, not going to work. An old clot from AFib, don't work. They need to go from a mechanical clot. But we try it.
Yeah.
Because now people are getting sued for not doing, lytic therapy for stroke. The standard used to be if you gave TPA or TNK for someone in cardiac arrest, you were committed to 30 minutes of CPR.
Really? I guess I didn't know that.
Want to get the drug in circulation.
Sometime.
And so the problem is, if you're a resource poor facility, you don't have enough people to do 30 minutes of chest compressions.
Long time.
A few times I've done it where I thought strongly that my patient in front of me had suffered an acute arrest around a pulmonary embolism. We have called all the nursing assistants from the floors. And at one location where we have a fire station like 2 blocks away, and we'll call them, and the firefighters will come to the ER and they'll rotate for us.
Yeah.
So it's been very helpful. It's a great, great thing. The problem is now the recommendations have changed. Now they're saying you need to do at least 60 to 90 minutes of CPR if you decide to give TNK to your cardiac arrest that you think is due to a pulmonary embolism.
Now,
so that really stretches your resources.
I can't, it'd have to be, I can't think of a whole lot of times that I would want to do that.
Yeah.
So,
my partner, just 2 weekends ago, we had a patient brought in from nursing home who had just been discharged from a lengthy hospital stay, who had a boatload of chronic conditions, most of which are risk factors for PE, along with this hospital stay. Apparently, it was noted that he'd had some left leg swelling at the nursing home, and now he's in cardiac arrest. And so I was not in charge of that code. My physician partner was. I was just kind of, hovering in a helper mode in the background. And she looked at me and says, well, can we give TNK to this? I said, you can. I said, but we're committed now to 60 to 90 minutes of CPR in someone who had poor quality of life prior to his arrest. And, we can do it, but weigh the risk benefit.
Yeah. Are we doing him any favors?
Yeah. So we decided not to give TNK just because we thought, number one, we were pretty confident it probably was a PE, but he'd been down for a while. We were now 30 plus minutes into this thing, and he had poor quality of life before, and now he's had 30 minutes of CPR. So we decided not to, because we knew we didn't have the resources to do 90 minutes of CPR.
Yeah.
It just wasn't going to be. So those are decisions you have to make on a case by case basis.
All right, let's get back to ACLS. we talked a little bit about the bradycardic algorithm and the medications that are used for that.
Yeah. So atropine's kind of fallen out of favor. Uh, so it's basically just epinephrine and pacing to see if you can get anything worked out.
Yeah.
Not much more to do for bradycardia than that. Good ventilation, good CPR, give your dose of epinephrine. There are some people that still will try atropine, but really not really shown to do any good for asystole. If it's truly just a bradycardia, especially not a high grade block like 3rd-degree block, it might help out. But if it's an asystolic rhythm or PEA rhythm, probably not going to help out.
Yeah.
Now, PEA, we got to figure out, is this true PEA or is this pseudo PEA, which is thought to be more of a extreme hypotensive shock? So this is where your physician or provider needs to lay an ultrasound probe on the patient's chest and look at the heart. If it's true PEA, your heart's not going to be doing. There's maybe a great looking rhythm on the monitor, or at least a potentially perfusing rhythm on the monitor. Pseudo PEA is there some heart wall motion. So this is probably more just significantly hypotensive shock. Probably doesn't need chest compressions, just needs an infusion of vasopressors to try and get their blood pressure up, and an infusion of fluids to get their pressure up. Let's see if that'll work.
Yeah. All right. What's the next algorithm here? Tachycardic with a pulse. What medications? Looks like it's the same medications. We're looking at, we got adenosine and iodorone on the algorithm here.
Yeah, so we got to decide, is this a narrow complex tachycardia? Is this a wide complex tachycardia? Is it regular? Is it irregular? A lot of things you've got to look at. If it's a nice, regular, narrow complex, patient's awake, alert, and stable, probably it's the umbrella term SVT. Is it atrioventricular reentry tachycardia? Is it AV node reentry tachycardia? If they're stable, then you can start off with vagal maneuvers. Anything that induces a Valsalva, so like bearing down if you're trying to have a bowel movement, ice water to the face, especially in a younger person, it might be a little more effective than an older person. But one thing that's changed in that is what's called the REVERT trial, where you have the patient initially sitting up, and this is a multi-person thing. They blow into a syringe, or into a syringe, like they're trying to blow the barrel out. Try to do that for like 10 or 15 seconds. And then when they can't do any longer, they stop. Someone lays their head down. Another person raises their legs up, and showed like about, compared to standard Valsalva, which worked about 17% of the time. And then in my article, REVERT worked about 42% of the time.
I remember trying it for the first time, and we tried it on this kiddo, and it didn't work. But I remember having seen it in an article or something, and then later one of the docs was like, "Hey, let's give it a try," and I was down. I was like, "This is going to be fun." And unfortunately, it didn't work. But I've certainly seen that it did have a higher rate than just your typical vagal maneuvers.
Yeah, so I've used it a few times, and people who have recurrent SVT who hate how adenosine feels, they'll try it every time. Let's try it one more time. Okay. And then they get adenosine, and then they feel like shit, but it can burst them.
And speaking of adenosine is the coolest drug ever to watch given. I remember the first time I watched adenosine given, and they were like, I'm okay, I'm going to slam this med. Now I want you to look at the patient. I want you to look at the meds. I want you to look at the monitor. And the first time I seen that big, long, straight pause. And I just remember thinking to myself, holy crap, we just knocked out this guy's heart rate. Yeah. And next thing you know, it was back. And I was like, that's cool.
And so, little caveats about adenosine, one, please, especially if this is a first timer who's getting adenosine, let them know they're going to feel chest pain and pressure and flushed and hot, and they're going to feel like they're dying. And they do.
The first time we seen it, the guy's like, "Oh, that feels terrible."
So, a lot of what I have started doing myself, and this is supported in the literature, and especially in patients who have had adenosine before and don't want it again if they can avoid it, is I give diltiazem, 50 milligrams in a 50 cc bag of saline, and run it to go in over 20 minutes. That has a higher conversion rate over adenosine.
Oh, really?
And without those very uncomfortable, I'm dying side effects.
Without those very uncomfortable, look at my heart stop.
So I've gone to using that routinely for those obviously stable, high blood, normal blood pressure, not crushing chest pain, patients who just have, hey, doc, I'm back in SVT. Can we not give me adenosine this time? So yeah, I got an alternative.
Yeah.
So, and it's supported by the literature. So it works. It just hasn't made it into the algorithm yet as a first line. And I just read an article last night where there's a couple of people who are still advising that adenosine should still be the first drug. Again, if someone's had adenosine before and they are really dead set against it, I'll just take a diltiazem drip, and it works great.
That's awesome.
In 50 over 20 minutes, and you're off to the races.
Nice.
So then, if it's an irregular, narrow, complex tachycardia, so a flutter, is it AFib? Those are the big things to think about. One thing that often gets overlooked, and I'm guilty of it, anybody else is multifocal atrial tachycardia, which can look like AFib if you're just, oh yeah, it's AFib because it's irregular and it's fast. Think about it in patients who have COPD, who come in with a rapid irregular rhythm. Take a really close look at a lead that gives you a good look at the atria. That's usually like lead V1. If you just do a 12 lead, like at the bottom of a 12 lead, you might have one or more rhythm strips across the bottom. Where I work, we get 3. So one of them is lead V1. So you get a nice good look at the atria.
Yeah.
You can also do what's called a Lewis lead placement of electrodes that lets you look at the atria better. And so
where does the lead go for that?
To do a Lewis lead EKG, the right arm electrode is moved to the manubrium. So right at the top of the sternum. So your right arm goes to manubrium. Then the left arm electrode is moved to the right 5th intercostal space adjacent to the sternum. So kind of just like, here's your right arm, here's your left arm. And then the left leg electrode is placed on the right lower costal margin. So kind of over here in the lower right part of the chest. And then you read on your EKG what would be lead 1 when it prints out. And that's your lead. Now, lets you see atrial activity much more clearly. So it lets you to see if it's AFib or a flutter or perhaps multifocal atrial tach.
Got it.
Multifocal atrial tach, the treatment is treat the problem. COPD, hypokalemia, hypomagnesemia are the big ones, and it will go away. In fact, I had one of these just last week. Yeah, first looked at the EKG, I thought, oh, it's AFib. Well, wait. No, that's not AFib. That's multifocal atrial tach. So you got to look at it.
Yeah.
And he had bad COPD, and his K was like 2.3, and his MAG was 1.1. So fixed all that, and came back with sinus rhythm.
Yeah, you're like.
So, but for AFib, atrial flutter, and if it's rapid and they're stable, then you can choose either a calcium channel blocker like diltiazem, or if they got poor stroke volume, poor LV function, using a beta blocker in their control. Now, if they have presented early, this is someone who's got no history of AFib, they said, hey, doc, 5 hours ago, I was sitting at home, all of a sudden my heart just started racing. It's been 5 hours, and you come in and they're in rapid AFib. There's an argument to be made to just shocking them. If you have a clear onset of symptoms. If it's been more than 48 hours, then no, they probably have had time to develop a clot in the heart.
Yeah, you got
to stroke.
Anticoagulate them first.
Anticoagulate them. They got to have a TEE, and then they might get 2 to 4 weeks later, but you're not going to start that way. But if you got someone who says, hey, doc, just a couple hours ago, I was feeling fine, all of a sudden my heart just started racing. That's a good candidate to risk shocking them and get them out of it before it causes any problem.
Yeah.
But then you do your workout, check lab, check their MAG or K, their TSH, all that good stuff. But you save them, drug therapy for a long time. But if that's, a person who has a history of AFib and it's intermittent, they may not be on anticoagulation, you got to feed with drugs. And so calcium channel blocker like diltiazem, if they've got good heart function, say you've had a recent echo that you can look up in the records, and it's not, a beta blocker like esmolol or metoprolol, things like that.
Yeah.
Now, what's really fun, and this is my favorite rhythm to take care of, is wide complex, irregular tachycardia. That is due to an accessory pathway like Parkinson white.
One of the questions, so I posted on social media today, hey, what questions do you have? And one of those was the treatment of WPW.
So treatment of WPW depends upon how they present with their rhythm. So it can either be narrow complex regular, wide complex regular, or irregular rhythm with alternating wide narrow complexes. That's WPW with AFib. So let's start off easy. They've got WPW on their baseline EKG. They got that delta wave. They got that slurring between the P and the QRS. They got that short PR interval, which you may not see every time, depending upon where that pathway is located. If you see it, say, oh yeah, they've got WPW, and they come in with a regular, narrow complex tachycardia. That's telling you that impulse is going through the AV node, down to the ventricles, then back up to the atria through that accessory pathway. It's just doing that circular movement.
Circular motion, yeah.
In the anterograde direction. Okay. It's going down the AV node normally, but sneaking back up through that accessory pathway back to the atria, and round and round and round it goes. We have to just break that cycle. Adenosine's great. Stop it right there because it's an AV node blocker, and you fix it. Let's say they come in with a known history of WPW, and it's a wide complex rhythm. That's telling you that the impulse is going down the accessory pathway first, then back up through the AV node, and round and round and round in a retrograde pattern.
Okay.
Same thing. Adenosine, boom, you block the AV node, you block that cycle, and they're out of it.
Nice.
So WPW, wide complex regular, narrow complex regular, treat it like it's an SVT, because that's what it is. Because you're blocking the AV. Where it becomes tricky and where people can get killed is if you apply that same drugs therapy to someone with AFib in a setting of Wolff Parkinson white. It's helpful if you know they've got WPW to begin with. May not always have that luxury. What tips you off is it's irregular. So, it's AFib. You have alternating or varied widths of the QRS complex. Some are wide, some are a little bit more narrower. Some are wide, some are more narrow. And you have sections on the EKG tracing that are very, very fast. Like the R to R interval is less than one big box. So those three things, irregular, alternating wide and narrow, and sections that show very, very fast rhythm. That is your clue that this is probably AFib in the setting of some kind of accessory pathway like WPW. You don't give the ABCD drugs. You don't give adenosine. You don't give a beta blocker. You don't give a calcium channel blocker. You don't give digitalis. You don't give amiodarone.
Yeah.
What happens is if you give those AV node blocking drugs, adenosine, amiodarone, beta blocker, calcium blocker, digitalis, that accessory pathway says, hey, it's all us now. There's nothing blocking. The AV node is there to block conduction, to allow time the ventricles to build blood. It's there for a reason, physiologic. If you block that AV node, all those AFib impulses from the atria are going down that accessory pathway.
Yep.
And AFib is 600 impulses per minute. Your ventricles can't do that, and you just killed them with BFib. So you avoid all the A, B, C, D drugs. You can give two drugs that start with P. Procainamide is the only drug and the drug of choice for AFib in the setting of Wolff Parkinson white or accessory conduction abnormality. The second P drug, propofol and chocolate. And you're probably just best just to shock them to start with regardless, because they're probably going to be unstable as fast as that rhythm can get.
Yeah.
But if they are stable, you can give procainamide a try. Understand it takes a while to load up, and you got to be ready to shock them anytime, because procainamide can cause hypotension and cause even further QT widening. So you got to have your defibrillator there ready
to go.
to either do synchronized cardioversion or if they do precipitate into VFib to defibrillate them. But, you avoid those ABCD drugs in AFib with W.
Yeah.
You will kill that patient. And I got vindicated a few years ago. I don't know, Tom Boothale.
That sounds familiar.
So he's a paramedic from Hilton Head who is a remarkable paramedic who does great things with pre-hospital care and resuscitation and everything. And he posted a couple of years ago on social media that both myself and Dr. Emil Batu were vindicated because American Heart came out and said, propenamide is the drug of choice for AFib with WPW. Because for years they were recommending amiodarone, and amiodarone can kill your patient because it blocks the AV node instead of the accessory path.
Interesting.
So that's my favorite arrhythmia. I've actually got an article published about it several years ago in the Advanced Emergency Nursing Journal back in like 2008 or something like that.
That's awesome.
That's my claim to publishing fame. Nowhere near some of our ENA colleagues who publish all the time, like Lisa Wolff and stuff like that. But I'm out there.
Yeah, she's hard to compare. She's hard to compete with.
I got too much other stuff to do.
Right.
And then so finally, those were the narrow complex, wide complex tachycardia. Assume it's BTAC. Unless you got, if they're stable in front of you, they're not having bad chest pain, there's something palpitations, their blood pressure's fine. You can delve into the history a little bit. Look at their old EKG. Does the QRS look exactly the same as their normal sinus rhythm? QRS, maybe it is an accessory pathway. Maybe this is an SVT with aberrancy or an SVT with a bundle branch block.
Yeah.
Then you can treat that as an SVT. But the rule of thumb is wide complex tachycardia is 5 things. VTAC, VTAC, VTAC. FVT with aberrancy, SVT with a bundle branch block. You will never go wrong treating it as VTAC. Now, there are some people who recommend if it's a stable wide complex tachycardia, you can give a trial dose of adenosine just to see if it will work. Adenosine will work if it's an SVT with aberrancy or bundle branch block. And in a few situations, it will work if it is truly VTAC. There's a certain type of VTAC, and I'm sorry, it's early here. I think it's the right ventricular outflow tract source where adenosine will work. The caveat to that is just because you gave adenosine and it worked does not mean it wasn't VTAC. So you can't just say, oh, that was SVT. So there's still a pathway it's still VTAC.
Yeah.
If you want to avoid that, then it's your stuff. You give amiodarone or lidocaine. And as always, having a defibrillator there ready to go in case they do compensate and need a cardioversion because drug therapy failed.
Yeah. Very cool. Any algorithms we left off or any other medications we need to cover?
No, those are the ones I wanted to hit. I wanted to kind of, the goals I wanted people to take away from our discussion today in our nice little conversation is ACLS is a good starting ground, and everyone should have that in their repertoire. If you're going to be working in a hospital, working with patients, I think everyone should go through it at least once. But as you become more experienced, more seasoned, I think there is a better, perhaps not a ACLS course per se, but some kind of resuscitation update on a regular basis, and having someone at your hospital who stays up to date on what's new. I get phone calls from my physician partners at night saying, can I send you an EKG? Love to. We're a team, we work together, and it's my fun thing to do. It makes me feel good that I can help them out. I'm a good resource for our team. So I like being able to do that. And for them, I've even answered questions from people overseas. You take a look at the CKG.
I know. I certainly sent you a rhythm. I remember sending you a rhythm that I was like, someone asked me what it was. I was like, I have no idea. I was like, but I know
I love doing
ask.
I love helping people, expand their knowledge and, understand things better. So number one, stay current on the research.
Yeah.
And ACLS may not always be as up to speed as some other things are. So having that resource person who is reading the late breaking journals, who's using free open access medical education, or FOAM, as we call it, if you want to follow me on social media, 90% of the stuff I post is related to what we're talking about today. Critical care in the ER, in the pre-hospital environment, in the ICU. If you can deal with my 10% of cats and fountain pens, then we're cool. But so, staying current is the most important thing. Having ACLS as that background of core information. Doing good, high quality CPR, limiting those interruptions, keeping those hands close to the chest during those pauses for defibrillation, making sure for defibrillation your pads are placed appropriately, especially that lateral pad, which is often misplaced. Consider alternative defibrillation, the vector change, the dual sequential. Starting epinephrine, sure, everyone should get a dose. What you do after that first dose, you might give more, you might give less, you might not give any more after that, depending upon you got running the code. There is a role for nurse-led codes. By that I mean, you got your physician or other provider who's overseeing the whole thing, but say they're getting tied up in a procedure, they're doing an intubation, they're trying to place a central line. Having a nurse who knows how to run a code, they're there monitoring. Okay, hey doc, it's time to give epi, or not even having to ask the doc. Just say, they're going to run some protocol until that doc gets free, who's not going to be distracted by doing a procedure.
Yeah.
So there's a lot of research that shows having that nurse that can lead the code during those points during resuscitation where the doctor is tied up doing something, and you don't want to distract them. They're trying to put a central line in someone's internal jugular vein or something like that.
Yeah. Yeah.
Don't bother them with, hey doc, can we give, another dose of epi? Freaking give it.
Yeah. And
it's our protocol. It's all the protocol I'm done here.
And that's how we do it in our department, in our hospital is we have kind of a nurse-led code where the doctors are doing the things that only the doctor can do. They're doing the intubation, doing a central line if we're doing a central line, and making suggestions outside of the typical, here's what we're going to do.
It also filter. Someone should approach them first and say, hey, I just got this bit of information from a bystander, who told, what happened. Then that nurse leader at an appropriate time tells the physician, hey, this is new information that might affect how we're going to handle this.
Yeah.
So you get that nurse led. And consider alternatives to defibrillation, do your epinephrine. If it's an ongoing shockable rhythm, consider amiodarone or lidocaine, again, understanding that it probably is not going to help. Probably esmolol might be your better drug of choice for that ongoing VFib patient. And knowing your different drugs for your tachycardias, and again, Parkinson's white with AFib, avoid A, B, C, D drugs. Just give either procainamide or propofol or whatever your sedation drug of choice is. Just shop it. Pick it up. So it's a lot of information. We could talk for hours on the different nuances of cardiac arrest. I know our focus today was supposed to be on drugs, but I did want to throw in there, the different alternatives for defibrillation and, some of the new drugs that are out there, just so people have a better, well-rounded idea of what we're.
Absolutely. Well, it's been fantastic. I really appreciate you taking the time to do this with me.
I appreciate you staying on.
I appreciate your wisdom. This has been fantastic.
So I hope people get something useful out of this. I am always available to your listeners if they want to contact me. Probably the best way to do that is through either my Facebook or my Twitter accounts. Facebook is just me, Andrew Bowman. On Twitter, it's Andrew ACNP1 or acute care nurse practitioner 1 or at Andrew ACNP1. They can follow me along. Again, the vast majority of stuff I post is related to the stuff today that we talked about. Critical care, emergency care, pre-hospital care. What are some of the late breaking research from some of the big minds in resuscitation medicine of today, like Scott Weingart is one.
Nice.
Stuff like that. So, and then, happy to answer any of their questions they have. They want to reach out to me at some point and help them in their knowledge base and in their career.
Cool. Well, we'll definitely put a link to your social media accounts in the show notes that they can find them there. And we'll definitely be tagging you when we post this. We'll definitely be tagging you in the post as it goes out. Cool. This has been a lot of fun. I really appreciate you taking the time to do this with me.
Well, my pleasure. My pleasure. I love talking about resuscitation. I love talking about some of the nuances. And for the really nerdy people out there who've got really aggressive docs in their ER, if you got someone in VFib and you're doing CPR, you've done your shocks, you've done your vector change, you've done your dual sequential, you've done your esmolol, you've done all the drugs, you can do a sympathetic ganglion block where your provider can take an ultrasound on the neck, find the left side sympathetic nerve branch, lies pretty close to the carotid and jugular vein, and inject next to that nerve sheath lidocaine or bupivacaine or marcaine to block that nerve function and try and stop VSIP. I've seen it done once in my nurse practitioner clinicals for a patient in the ICU who was having frequent recurrent VTAC electrical storm, and they couldn't get it to stop with drug therapy. So the cardiologist did this sympathetic ganglion nerve block and stopped his VTAC.
Wow.
I've not seen it deployed in the emergency department.
No.
There's people who have done it, and it's in the literature as kind of your, Hail Mary pass to stop the VFib, especially if you got someone who started out with high quality of life before they coded. It's one last thing you can try and do for that persistent VFib. Stick it in their neck and block their sympathetic nerve. My friend, I hope this was useful to your audience.
I am sure it will be. And again, thank you again for spending so much time with me. And I think people are really going to dig this 2-part episode. Thanks again. See ya.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.